Hello, my name is Jamie Simpson, and my presentation is on ketamine as an opioid adjunct treatment in laminectomy patients. Evidence suggests that low-dose ketamine infusions can significantly reduce the need for additional opioid medications. Effective pain relief while minimizing exposure to drugs that carry a high risk of dependency and adverse effects. Postpartum ketamine not only reduces overall opioid consumption within the first 24 hours, but also resulted in noticeably lower pain scores within the first 48 hours after surgery. Ketamine may also reduce the need for additional opioid pain medication treatment in patients who are post-operative from laminectomy surgery. It is best practice to support patient pain management while attempting to limit overall opioid use while recovering from spinal surgery in the hospital. Ketamine's potential to curb opioid use without sacrificing comfort makes it especially relevant at a time when clinicians are striving to manage pain responsibly while protecting patients from long-term harm. Opioid use has become an epidemic in the United States. The pain associated with spinal cord surgery increased the risk as patients may be introduced to opioids following these procedures. Postoperative pain following laminectomy surgery is typically managed by the use of intravenous and oral opioid medications. These medications can lead to adverse effects such as nausea, respiratory depression, medication tolerance, and medication dependence. Opioid use after laminectomy surgery can lead to longer hospital stays and higher readmission rates. In a large study, 1.7% of patients developed a new persistent opioid use disorder, and 6.8% of these were spinal surgery patients. They're very likely to develop an opioid use disorder after surgery. The PICOT question is, in adults undergoing laminectomy surgeries, how does the use of intravenous low-dose ketamine infusions as an adjunct to standard opioid pain management compared to standard opioid-based analgesia alone affect post-operative pain levels and opioid use within the first 48 hours after surgery? For the search strategy, I used the University of St. Augustine's library and I searched different databases, and some of these included the CNAL, PubMed, Google Scholar was used at minimum. The searches were limited to the years 2020 to 2025 to ensure up-to-date research. Peer-reviewed nursing articles and medical journals were prioritized. English language studies conducted in the United States were preferred, and key search terms such as laminectomy and opioid independence and ketamine and opioid use, laminectomy and hospital stay, etc. These kind of terms were used, and research supporting the PICOT question were used and focused on ensuring research applicability. Using this search strategy, there was good results yielded, and I was able to find a lot of information on this topic. Synthesis of the literature. Overall, the evidence trends, recent evidence between 2021 to 2025 consistently showed that low-dose ketamine as an adjunct to standard opioid therapy reduces postoperative pain consumption and pain scores after spinal surgeries. Overall, the synthesized evidence supports the use of low-dose ketamine as an effective and safe adjunct to traditional pain management for postoperative spinal surgery patients. Research also shows benefits in reducing opioid consumption, improving pain control, and reducing opioid-related complications, making it a good intervention to improve recovery outcomes. Also found that ketamine should be initiated early in postoperative period due to the most favorable results in the most pain presenting in the first 24 to 48 hours. So there was consistency across the studies. All the studies that were reviewed showed consistent improvements in pain management and reduced opioid consumption when ketamine was used postoperatively. And here's just a slide that kind of breaks down some of those studies and what they found. Recommendations. The recommendations would be to use low-dose IV ketamine as an adjunct to opioids. Typical ones that are used, oxycodone and morphine. Another recommendation would be to start the ketamine early in the postoperative period within the first 24 to 48 hours when pain is peaking. Dosage would be prescribed by the doctor based on different patient factors such as age, weight, prior medication use, and any other pre-existing conditions. Safety monitoring would be another recommendation. We would train the staff to watch for side effects and adverse reactions and support staff with additional resources, training, and documentation requirements and understandings to keep everyone safe. The setting for change. The practice change will occur in acute care hospitals and on the orthopedic postoperative unit where adults recover after laminectomy surgeries. Patients on this unit typically experience significant pain during the first 48 hours after surgery. The stakeholders in this include the care team, so it would include the surgeons, anesthesiologists, advanced practice providers, bedside nurses, pharmacists, people who come in contact with the patients who are in recovery. The proposed plan and change model, we'd be utilizing the Lewin's change theory. It's a three-step theory or a three-step model, unfreezing, moving, and refreezing. So in the unfreezing, preparing for change step 1, we'd be identifying the need for change and create motivation among the key stakeholders, present current postoperative opioid usage data for these patients, and educate the surgeons, anesthesiologists, pharmacy, nursing staff on the new evidence that supports this change. In the moving stage, we'll be implementing the new practice recommendation. So we will use the ketamine adjunct protocol with a small group of these post-op patients, and we will provide training for the nursing staff on infusion protocols, monitoring, recognition of adverse effects, and everything they'll need to know to safely care for these patients. Integrate the ketamine protocol into the postoperative order sets and offer support with this training. In stage 3, the refreezing and maintaining the changes, we would evaluate the data on the opioid consumption and pain scores and see how it has affected patients who are undergoing ketamine treatment. We would finalize the protocol and make adjustments based on feedback and data, and integrate the protocol permanently into the organization and reinforce this through staff education, audits, refreshers, and trainings. The evaluation plan will focus on determining if the low-dose ketamine infusions improve pain control and decreases opioid use within the first 48 hours of laminectomy surgery. So we would count the total opioid consumption. This would be measured through the EHR, medication administration records. We'd also look at reduction in opioid compared to the baseline. Pain scores also measured through the EHR, and we would use the numeric rating scale of 0 to 10, and we would check those for their ratings that should have been recorded every 4 hours. And we would look for a reduction in opioid use compared to standard opioid use alone. We would also look at the unwanted effects, which would be identified through documentation in the EHR by the staff, and a decrease in postoperative opioid-related adverse effects would be expected. We would also look at hospital length of stays, and those would be measured through looking at the discharge records. And so we would expect to see a reduction in average length of stay for the patients who were on ketamine as an adjunct. Data collection and analysis. So data collection would be opioid administration data from the EHR. We would check to see how often opioids were administered to patients who were on ketamine protocol. We would check pain scores, also collected from EHR, and that were given from patient feedback, adverse events, and length of stays. The Analysis of the data would be done through a chi test, which is a test for consistency in data. It's used to determine if there is an association that is significant between the two variables. Plan for dissemination. Effective dissemination will support long-term adoption of the new protocol and will contribute to evidence-based pain management practices. Presentation of results to surgical and anesthesiology teams to promote understanding and the need for change. Involve the hospital staff and provide verbal and written information on research and the development and implementation of the educational training to support this. So in conclusion, the PICOT question explored whether low-dose intravenous ketamine reduces opioid use and pain after laminectomy surgery. The evidence shows that ketamine can effectively decrease opioid consumption and improve pain control within the first 48 hours. This reduction in opioid use may also lower the risk of side effects, shorten hospital stays, and reduce opioid dependency. Multiple studies consistently support the use of low-dose ketamine as an adjunct to standard opioid therapy after spinal surgery. Practice recommendations include starting ketamine early in postoperative period, alongside safety monitoring and staff training. Overall, low-dose ketamine appears to be a favorable and effective option for improving recovery outcomes in patients after laminectomy surgeries. And here's a list of the references used to compile this presentation. Thank you.